or a family member who has emphysema, which is a disease that affects the respiratory system, the lungs, and it is worsened in the recent past, you are very worried because you are the main caregiver. If he becomes too ill to breathe on his own, what would he want for himself? He's about 8 years old. How much should doctors intervene? If he is not able to make his own medical decisions, who would he want to speak on his behalf? You are very uncomfortable raising these questions with him. And when you finally do so, he waves you away and tells you, when the time comes, you will know what to do. That's what he tells you. His condition is worsening. Who makes the decision for him? So advanced care planning is a process. So it is a process that communicates information about the patient's or a person's diagnosis or lack of diagnosis, treatment options as of that given time, life goals, values, and wishes. So it's not just about one component. It's not about diagnosis, not about treatment options. It's about all these 5. Diagnosis, which diagnosis, of course, has to come with prognosis, treatment options that are available. What are the goals, life goals of this patient? What are the values that this patient hold dear? And what are their wishes? 5 components of an advanced care planning communication process. And such, it involves the patient, loved ones, the next of kin or the family members, the healthcare provider members, be they healthcare professionals, be they clinicians, or anybody else engaged in the care of the patient. And as such, it is not a one-off activity. It's a process. It's an ongoing conversation between all these players. And it's critical to know that having these conversations will ensure that the patient preferences are known beforehand by the healthcare team, and when the time comes for them to be implemented, they will be incorporated into the current care plan for the patient and moving on for the future healthcare plans for the given individual. We are calling this person a patient, but sometimes you don't have to be sick to have an advanced care planning. Now, this process can take so many shapes. It can take so many meetings. It can take so many conversations. It can have a lot of flexibilities. But when eventually pen is put to paper to give the guidance, to give the way forward, the preferences and the wishes of this patient, the product, the document so signed is called advanced directives. So the product is advanced directives. The process is advanced care planning of the patient saying, this is where I want to be taken care of. This is what level of care I would wish for when I cannot make decision for myself. And this is the person who should make decision for me when I'm not in a capacity to make a decision for myself. As such, it is very important to have the advanced care planning. And some of the reason is, look at ourselves. We all want the opportunity to participate in our own medical care. I don't want someone saying that let's give him an injection instead of an oral tablet. Let's admit him to ICU and I should be engaged. And that's why the principle of respect for autonomy come out very, very clearly. And the principle of respect for autonomy outlives the capacitation of a patient. If the patient have given guidelines in form of advanced directives on what they wish to be done when they are not in a capacity to make a decision. But this is not always possible for us to be engaged, because sometimes we get drugs that sedate us. Sometimes we are sedated as a part of medical intervention. Sometimes we have very serious medical conditions that affect our cognitive power, our power to be aware of our environment. Think of dementia. Think of patients who have stroke. We also get drugs which could reduce our capacity, power to make decisions, or actually to give consent or to guide the treating and care teams. So lack of capacity for autonomy is critical. So the only way to ensure that bullet number one, that we have the opportunity to participate in our medical care when number two comes, is by doing number three, that we have a voice in our future care and giving the wishes that should be known by our loved one, by our family members, by the stakeholders in our lives, and also by our healthcare treating teams and institutions. And this is in the form of advanced directives through a process called advanced care planning. And at the end of it all, what does it do? It empowers and enables the patient and the families to make sure that whatever is being done is for the patient, by the patient, in the interest of the patient, so that we are not fumbling in the dark about what should be done. They clearly stated this is what should be done. They clearly wrote, signed, documented, and recorded what should be done. It does facilitate shared decision making. As we said, the conversations, the interactions to make a decision is by the patient, with the family, with the healthcare provider, and with all the other stakeholders in the patient's life. But of course, it also encourages better provision of services related to the patient's needs. The patient needs and pre-planning of care, because the patient's needs are not default. We know we have guidelines, we have protocols, we have policies, we have all this. Those are texts telling us when a patient comes to a point where they meet the criteria for being intubated and escalation of care to critical care ICU, HDU, that is the default. But then what are the needs of the patient? So ACP, Advanced Care Planning, does encourage provision of care related to the patient's needs, contextualized to the patient wishes, and by the setting of the patient. Now, when we consider ACP, all of us should be having advanced directives. I won't ask this question, but I would have asked, how many of us have advanced directives? How many of us have had advanced care planning discussions or decisions with either our family members, our legal officers, our lawyers, our treating doctors? But then, housing it within our healthcare provision on assessment of individual need. You will talk to some patients who will tell you, this is where I would wish to be, this is what I would wish done to me. But also sometimes life-changing events like loss of a spouse, loss of a loved one, does provide our patients with concrete evidence and examples that this should have been done. Because sometimes we have people asking, if only he had expressed his wishes, if only he had said what he'd want to be done. I'm lost making a decision for him or her because I'm not sure of what they would have wanted. And this is the conundrum that family members, healthcare providers, and caregivers do face when taking care of patients. So sometimes when you have life-changing events, then people do make a decision. And I think we had an upsurge of uptick of advanced care planning and advanced directives. After COVID-19, people came and were saying, yes, we want these discussions following a diagnosis of life-limiting condition. And I believe this should be a must discussion and a must conversation with the patient following the diagnosis of these life-limiting conditions, which are many, not only cancer, but all the others. And also, when you admit a patient to the hospital, do we ever inquire from the patient what level of care they would wish to have if they are not able to make a decision? Nobody is assured, even if they came with simple diagnosis of diabetes, hypertension, malaria, that they will get out of hospital. Anything can happen. We're dealing with bodies which can suffer from any situation, anytime. So on hospital admission, on hospital reviews, in the clinics, it's good to have these discussions. So consider this as part and parcel of healthcare provision. And in the well-developed places and well-developed countries, one of the key indicators of quality care provision is the discussion about advanced directives with patients, with loved ones, when we see them in the healthcare settings. So sometimes we ask ourselves, what are the patient's goals? And we know, we say patient to be free of pain, to be treated the way they want. You and I, even if you are to be patient or wherever we are, we want to be treated the way we want. Sometimes we say we don't want to be connected to the vent, the so-called machines, not to be admitted to ICU, HDU, not to be a burden to our families. When the time comes, let me go. I don't want to use the resources of the family. I want to pass on at home, not in hospital. And this is taking cue. It's becoming very, very common to have close family members near me to maintain my dignity, be it individual dignity, objective dignity, to have my financial affairs in order, to say goodbye to my loved one, to my friends, to my social networks, to have my family prepared for my passing on. All these bullets come to only one thing. As human beings, we are powered because we are rational and listening. We are powered to believe that we need to have self-determination. And this self-determination will emanate from self-realization. The self-realization will have to come from self-actualization. Once we have these three, it's the duty of healthcare providers to at least give some input for eventually the person who have self-realization, to have self-actualization, to have what we call health literacy. Health literacy means the patient is aware that they have the power to make a decision, they have options to make the decision, and the option to make the decision is now, not only for the decision today, but for the decision tomorrow, and the decision 50 years to come, and the decision when they are not in a capacity to make a decision. Eventually, this is what is called self-determination. So the patient can say, I want to be free of pain, to be home, to be with my loved one. But what are they telling you really? It's self-determination. It can never be true self-determination if they only want to be free of pain, to be near their family, but you have not empowered them to have health literacy. And one of the key to health literacy is making a decision for yourself now and even for the future. So we have some types of advanced directives that are practiced. And there's one called living will, which is a legal document which states certain future healthcare decisions that should be done only when a person becomes unable to make the decision and choices on their own. So a patient says that when I'm not able to make a decision for myself, do not take me to hospital. When I'm not able to make a decision for myself, do not put me on the ventilator. When I'm not able to make a decision for myself, I don't see any reason of you doing laboratory CT scans and all those investigations. But of course, this has to be contextualized within how the patient is, the illnesses, and what they see. So the patient make that decision. But there's another type where the patient has what we call medical power of attorney, or the holder of medical power of attorney, meaning the patient names a person who can be called a proxy, who will make all healthcare decisions if the patient become unable to do so. Remember the first one, the patient made a decision, they said, do not do that. But sometimes a patient might make that decision, But then say, if there are other questions beyond what I've decided, then these can always be decided by my proxy, the holder of medical power attorney, the designee, the delegate, the person who has delegated power of attorney for healthcare. Now, the difference between these two is the first one is by the patient, done for the patient, and they have made their decision. It becomes very confusing when the accordation comes that was not named by the patient. And that's why combining these two, a living will together with medical power of attorney, gives us a more flexible way of dealing with this patient. Because if it comes to maybe an intervention that was not there when the patient made their living will, then we'll be able to discuss with the holder of medical power of attorney, the next of kin, or the person who has delegated decision-making power by the patient. So we realize that most institutions will combine these two. But there's also a document called limitation of care. Patient will say, take me everywhere and anywhere, but please, when it comes to intubation, don't. When it comes to resuscitation, don't. When it comes to giving me chemotherapy, please don't. When it comes to giving me food through the vein, through the nose, the so-called artificial nutrition and hydration, do not. So that is limitation of care. And we have to obey these limitations. But also when they give these limitations, they need guidance from healthcare providers. Because if you say, yes, you can do CPR on me, but you cannot intubate, then what was the essence majorly of doing a CPR without the reason of intubation? And the big animal in the room is DNR, do not resuscitate, which can have as many as 20 elements of resuscitation, can have as few as 2, depending on what you're looking at. So there'll be, of course, intubation, there'll be defibrillation, there's going to be mechanical ventilation, there's going to be advanced airway management, there's going to be hemodialysis, there's going to be inotropic support, there's going to be hydration, there's going to be the big ethical discussion about parenteral nutrition and hydration as part of resuscitation. So these are the types. And you can always sit down and ask yourself which fits you. And as you discuss with your patients and the people you are seeing in your clinics and all that, you might be able to make a decision on which one they prefer and take them through. Because as we have said, for self-determination, health literacy is critical. And health literacy literally means that you're cutting across the 4 elements of principles of medical ethics, starting with the clause on autonomy and followed by the others. As we move on, it's not a cut and paste, copy and paste. There are considerations that we do, and we've seen some dangers of just saying, yes, here we have advanced directive, and we are starting the issue of advanced care planning. This is the discussion because we want you to make a decision for us on the level of care. Please make sure that you approach it in a holistic way. Patients have got so many other considerations that need to be done. Just to mention a few, existential considerations. Where are we going to? Where are we headed starting at this point of this conversation? Is it in the background of a life-limiting illness, in the background of dementia, in the background of cancer? Is it in the background of multiple chronic illnesses? What are we doing right now about it? And what is the patient thinking and doing about it? And as we continue, we said we are rational and listening. This makes life interesting. There's diversity. So what is the meaning of this patient's life? Because even religious views about death are very, very important. We are talking about a patient who is saying, when time comes, do not do this and this to me. So it's about end-of-life care decisions being made when someone is very, very healthy. And you look at Christian views of afterlife. Protestant will view heaven as something that once you have faith, for example, then you are good to go to heaven. But then Catholic will have the purgatory power. That there is that place that is inhabited by the souls of the sinners as they are cleansed to go to heaven. What does this mean when you're discussing about advanced care planning and advanced directives for these patients? And of course, about the incarnation and the issues of Muslims about burial. Right. So these factors must come into the fore. And sometimes these documents, when we are discussing with them, we forget about these considerations that need to be discussed with the patient, and also, if need be, with the loved ones, because they're very critical for us to bring the holistic nature of these decisions. Cultural considerations are very, very important. Yes, we have advanced directive document in the institution that is done by the patient. We have change of goals of care that is done by loved one or the holder of medical power of attorney. But a patient holistically has a culture. The culture that has ethnicity with the people that they have lived with. They have a belief system with traditions. They make a nation. And this diversity is what makes advanced care planning interesting. So cultural relativism and diversity cuts across. Sometimes death is a taboo to be discussed. But when it comes to a person 80 and above or 70 and above, it's celebration of a life well lived. But when you're talking to these people about advanced care planning, then they say, yes, I've done my bit. But think of talking to an African man or lady who is in their 30s and 40s about advanced care planning. They still have a lot of expectations from the society. They still need to bring up families. So death as a taboo has to be taken within the realm and environment of that patient's cultural environment. And then the fact that it's happening to this single person, they have their belief and where they come from. There are people who still believe that they need to be interred and buried where the placenta was buried. You're discussing with them about advanced care planning and directives to be decided in Nairobi. But they come from about 400 kilometers away from Nairobi, and they would wish to be there. That's a key component for you to bring in. Are there specifics about your culture, about your belief, about where you'd want to be interred? Of course, the sick role by this patient takes away the patient's voice and autonomy, but does not take away the patient's wishes, the respect for the patient's wishes and preferences. They might have lost a voice, they might have lost the autonomy to make a decision, but to give them power, for them to take over the power, is for them to have a predetermined decision made for them. And then that will bring us to relational autonomy. How to relate with others, who makes a decision. Do we use a hierarchy? Or do we literally need to go to a specific person for this decision to be made for this specific person? Then the other consideration is about quantity than quality. And this is a contemporary cultural consideration when it comes to advanced care planning discussions. Is it about quantity of life? Is it about quality of life? Is it about quantity of care, or is it about quality of care? Is it about quantity of interventions, or is it about quality of interventions? When you show a patient that at the end of it all, when they are not able to make a decision, they have a life-limiting illness, that doing those many tests and all that might not be of benefit, then they'll reconsider. It's very important to consider that this is a critical component of the discussions. Sometimes you'll have people need to be in the hospital at the end. Sometimes it's because they don't want to be accused of neglect when someone passes on at home. About 40% of our patients come back after being on home-based care for 3-4 months because they want to pass on, the family want them to pass on in the hospital so that they don't have that burden of that 8 minutes or 8 hours, or actually they are not accused by society of neglecting that person. In a few cases, we have the other way around. The patient is very sick in the hospital, things can only be, but the family is saying, let's go home to enjoy the last days with the family. It's a key component of advanced care planning. We might miss them, but when it comes to that decision making, families are conflicted. Yesterday we had a case family wanted to take a patient home from ICU. And we were telling them the condition the patient is in and the kind of support they might pass on even before you leave the gate. They said, yes, we can sign a LAMA, but how do we make sure he get home? When they came to hospital, the patient was very sick last week. We did not have this conversation because we could just have stabilized the patient and taken the patient back home. So remember, it's not copy and paste. The preferences of the patient and families have to be taken into consideration. And the practical considerations are also very critical. Do we have time to have these conversations? Sometimes they are very draining. Prognostication criteria, cues, skills are still very limited from where we sit. And when that question comes, then we are lost on how to go about it. These conversations and discussions are very difficult. You have to have critical communication skills on how to initiate, because the commencement of advanced care planning discussions is by the clinician, is by the treating doctor, one of the caregivers. How do you initiate? At what point do you initiate? Is there an objective criteria to say this is the time to start? But as we have said, it's very contextual, very individualistic, based on your patient, based on your skills, based on what you as the care provider think is a key component of health literacy for your patient and the loved ones. Of course, practical challenges with documentation. And as we have seen, there's the living will, the medical power of attorney, there's the do not resuscitate, there's the change of goals of care. So how do we document? And are these documentation domiciled within the guidelines, within the policies, within the laws of the country? So these are some of the practical considerations that we need. Remember, advanced care planning discussions do not have to happen in the hospital. A patient can come to you, just walk in and you have the conversation. They can happen in outpatient clinics. They can happen at home. So those practical considerations are critical, but key of them all is communication skills on how to initiate and commence these discussions with the patient and also the stakeholders in their given lives. Then, of course, the issue of language is a critical practical consideration. What is advanced directives in Swahili? What is advanced directives in Tholuo? What is advanced care planning in Swahili? And is the language as spoken the same as the language as understood by the patients? How do we simplify the language of advanced care planning, holder of medical power of attorney, next of kin? And we know generally, traditionally, the next of kin is the one who makes decisions. Are they the same as holder of medical power of attorney? Or do we have guidelines for this? And these are critical points for our discussion. So some benefits of advanced directive that we've seen is patients will receive care that is consistent with their preferences. That single bullet is the most important benefit. It also facilitates communication. Now, when patient desires are met, patients, loved ones, clinicians have a peace of mind with little and less moral and ethical distress. And therefore, there's reduced stress, reduced conflicts between clinicians or treating teams and the patient, between patient and family members, between doctors and family members. And certainly reduces depression for surviving relatives and advocates that reduce. So at the end of the day, we are looking at having advanced care planning, not only for the benefit of the patient, but also so that we reduce the likelihood of occurrence of pathological grief by the family members, by the loved ones. And if you look at these 5 points, it will guide us to have those contextualized discussions, and the moral ethical distress that is reduced by clinicians cannot be overemphasized. Because when you talk about futility of care, to whom is it futile? is that when we say this is futile care because it's medical, does medical futility of care equate to social futility of care? The only way to answer that question is to have a discussion with the patient when they are in a capacity to have the discussion. And during these discussions, we engage the family members. What is the situation in Kenya? We know that advanced care planning has made strides all over the world. So there are laws everywhere about advanced care planning, more so in the Western world. In Africa, South Africa has a law on advanced directive. Unfortunately, one of the countries with the highest laws per state in regard to advanced care planning is the US. But don't be surprised that 75% of US citizens do not have advanced care planning. So it might appear to be just starting, but I believe we are headed somewhere. In Kenya, we have no specific law that talk about advanced directives. So you realize that doctors and hospitals and clinicians will lean more towards Health Act of 2017, will talk about autonomy and patient refusing any treatment when they're in a capacity or not in a capacity, but also the term advanced care planning and advanced directive is mentioned in the National Palliative Care Policy 2021-2030. 2023-2030. And that is a key point that we are working on, that because it is mentioned and it literally feeds into the power that the patient holds, therefore, using the Health Act 2017 and National Palliative Care Policy, therefore we can develop this document. So institutions have leaned on this to have institutional guidelines as far as advanced care planning, advanced directives is concerned. And this is what we did at Aga Khan University Hospital. We came up with advanced directive, advanced care planning process, change of goals of care, which are domiciled within the bigger and larger policy of palliative care and end-of-life care. So that's how we look at it. But there's no single given statute in the law that talk about advanced care planning. So we've done some studies at Aga Khan. One was when we looked at factors that influence advanced directive completion among terminally ill patients in our hospital. And we looked at about 180 patients. And the outcome was the bigger proportion had advanced directives. This is because we already have policies, we have documents, we already have guidance on these discussions. So the terminally ill patient in 2017 who are reviewed, whose documents were reviewed, were 58% had advanced directive. This is a very big number. And I know out there in the country at large, it's something less than 0.1%. And also we looked at what type of advanced directive they completed. So majority had what we call do not resuscitate or do not intubate as part and parcel. We had the second number that 8% had limitation of care document, detailing that we have all this you can do for us, but don't do these 6. And this kind of discussion are critical because the advanced care planning, advanced directive, they do not resuscitate, the DNR document are very, very flexible. It's not one fit all. It should be guided by the patient preferences and what also the family think should be done. We had about 3% with the living will, which was very, very interesting when they were asked and they had made their decision. But when we looked at this 3%, we had to have other discussion with the family when it came to some aspect that had not been captured in the living will by the patient. Then the factors that were associated with completion of advanced directive in this study were history of ICU admission is likely to initiate discussion in these situations. History of intubation, poor functional status of the patient, and medical specialty taking care of the patient was an interesting finding. So that internal medicine and pediatrics were the critical ones. Surgery, ops, gynae were few consumers of this, despite the fact that all the patients met the criteria of being termed as terminally ill. Caregiver discussing the advance directive with the patient was also found to be a critical element on completion. So some come when they have already discussed, have had these discussions. And a palliative care consult was found to be an important factor in informing this 58.43%. So these factors can be taken into consideration when saying, these people had advanced directive, they had change of goals of care, they had do not resuscitate. Then we did another study where we explored awareness of perception and the perception of healthcare providers on 3 specific areas: disclosure, family role in decision-making, advanced care planning and advanced directive, and artificial nutrition and hydration based on the principles of medical ethics. And we are looking at this using a cross-sectional study. We identified 5 sites within the country. Now we went outside Aga Khan and went to other parts of the country. And the questionnaire had 3 sections: demographics, knowledge and practice using case scenario. So knowledge and practice were Likert scale and case scenario. So 3 sections. And then when it came to advanced directives, and we asked, how likely are you to initiate advanced directives? Almost 80% said they would likely initiate advanced directive discussions. When you put a statement that they are culturally acceptable in a Likert scale, the same number that said they would initiate say that they are not culturally acceptable. Look at this, 80% we can initiate, but are they culturally acceptable? No. And undecided, 80% said undecided or they disagreed. This is an interesting finding because is it about theory and practice, or what is it about? When we put a statement that they are well received in the country, a similar number said they disagreed, but the same number that has said they are likely to initiate these discussions. So what is the problem with advanced directives? And we gave them a case scenario of a patient who was very sick, seriously sick, who did not have advanced directives. And this patient was at the end of life with a prognosis of about 5 days. And we asked them, would you ventilate this patient? 75% said yes, they would ventilate the patient. As a follow-up question was, why would you ventilate this patient who is seriously sick 5 days to life? And they said it's a medical duty to provide all care. 82% agreed it's a medical duty to provide all care. Do you agree, members in this forum, do you agree it's a medical duty to provide all elements of available care, irrespective of the fact that the patient is at the end of life, the last 3 days, the last 5 days, so that we are pumping them with antibiotics, we are pumping them with chemotherapy, we are intubating them, we are giving them everything despite the fact that the organs are shutting down. So the finding here is important for us to see. Why would they ventilate this patient? So eventually, we need to look at a way of improving uptake or improving discussions or improving this kind of interaction. Let's call it interaction in regards to people, patients, Kenyans making decisions about the level of care or the kind of care they would wish to have when they are not in a capacity to make a decision. One is to start the conversations early. As early as now, you're good, you're working, you're healthy, make your decision. Education, policy makers, clinicians, community, health literacy cuts across board. A key indicator of quality healthcare provision is when you have these discussions and you have these decisions made by the patients. We would wish to have a law strictly talking about the power of Kenyans to make a decision called advanced directive, so that we don't get into situations where family members or other stakeholders want to veto the powers and the decisions made by the patient. Then we do encourage physician-patient discussion. And this will have to make us and demand on us to have critical communication skills and to know that we are not talking about the order of life. We are not talking about death. We are talking about part and parcel of healthcare that we are providing to our patients, and in consideration of the fact that they will not always be in a position to make a decision. If you have a palliative care specialists, please do engage them because they are trained to hold these critical discussions with the patients and also family members. And also to train you as healthcare providers and other hospital staff on the critical element of advanced care planning. Then, as we say, there are so many considerations, religious consideration, cultural consideration. Look at it holistically. It's not what one decides, is what the other decides. It's not what you guide one, is what you guide the other one. Make sure that all the elements and the confounding factors in this patient's decision-making or care are taken into consideration. And this contextualization is what actually we found out that was bringing us to these findings, that the advanced directives as constituted today are Western-based. Sometimes we forget that the clinicians also do belong to a society that has got beliefs, that has got traditions, and has got a way of life. So you might train them that advanced care planning, advanced directive are good. So it's high time to talk about contextualizing advanced directive, Africanizing bioethics, Africanizing advanced directives, contextualizing them within what we think should be done, not what literally the Western world is talking about. For example, decision-making. We know the patient should make a decision. That is key. But some of our situation, family members are still engaged in decision-making. And this study, if you were to go further, you realize that we are not yet out of the woods when it comes to the single patient making a decision. It is still a communalistic society that we live in. Thank you so much. I wish to stop at that point, and then we can have questions, discussions. Thank you.
Thank you so much, Dr. Weru, for that informative session. This is quite an eye-opener, and we appreciate for this very informative presentation. I think at this juncture, I want to invite the other panelists to a discussion before we open the Q&A session. So, Dr. Esther Nafura.
Yes, Paul.
And Professor Wanyoro, maybe you can make some comment about the presentation before we embark on the
Hi.
panel discussion.
But I'm not a panelist. It's only my name goes there.
Prof, you are well invited in this.
The presentation was very good. Thank you, Dr. Weru, for that wonderful presentation. I think maybe what I can just add is that when we are having advanced care planning discussions, I think a lot of the time in our Kenyan setup, these discussions happen with the families. In fact, sometimes we end up discussing with the families before we even go to discuss about the wishes of the patient. And it's basically because of the way our culture is. We are a family-oriented society, and most decisions are made by family members. For example, when it comes to making serious decisions, even when you ask a patient to give you their wishes, sometimes you get a response, let me wait for my husband, let me wait for my wife, let me wait for my sister. We need to discuss this issue first before I can decide anything. So when we are having these discussions, it is good to consider the context and the culture of the patient that we are dealing with, so that we are actually able to have a sensitive discussion and get good decisions from them. And then the other issue is maybe just about the timing of the discussion. It can be held in the outpatient, it can be held at home, it can be held before people are sick. So it is good for us to focus on having the discussion rather than just signing an advanced directive. Remember, we do not have laws in Kenya that recognize advanced care planning or advanced directives. So even when a patient signs a DNR, for example, it still remains to be a hospital document that is used within the institutional policies. So the focus should actually be more on understanding the wishes and the kind of care that someone wishes to get when they are incapacitated or when they're at their end of their life, as opposed to just signing a form and ticking boxes that this is the kind of care that I want, or this is the kind of treatment that I do not want. So the focus actually is on shared decision making. I think those are the comments I have for now. Maybe we'll see the responses that come up and the questions as we go on with the Q&A session. Thank you. Prof. Wanyoro, I think we'd like to hear your comments as well.
Prof. Wanyoro, if you are still there, you can make your comment. I think we'll go into the Q&A section now. And one of the first questions I would want to ask Dr. John Weru is, how do we strike the balance of offering quality healthcare and advanced care directive, Daktari?
Thank you. Thank you, Paul. And what I believe this means is that quality healthcare means holistic, patient-centered approach to provision of any healthcare intervention, be it a test or a medical advice. So you cannot separate the two. Advanced care planning discussions and advanced directives are part and parcel of what we call quality healthcare provision. So when you come to the question on quality improvement, the world is tending to having these conversations as a key indicator or an indicator of the fact that quality healthcare provision has taken place between the hospital and the treating team and the patient on the other hand and the next of kin. Thank you.
Daktari, the other question, I want to throw it to Dr. Esther Nafura. And what's your take when the wishes of the patient contradicts, when the wishes of the relatives contradict that of the patient, who now becomes incapacitated and probably not able to communicate for their own?
It's actually a very common scenario, and we get a lot of conflict sometimes within the family. One side of the family tells you the patient wished that we, for example, we do everything possible, we resuscitate, we intubate, and the other side of the family is saying, no, the patient wanted to be home. So sometimes it's actually very difficult to get a consensus And when the patient is incapacitated, we cannot know for sure what their wishes are. But the approach that we take is actually to have a family conference and try to get a consensus from the family members so that they can agree on the way forward in terms of what level of support, how aggressive the care should be. So ideally, it would be best if we had the decision from the patient. But when that is not possible, then we heavily rely on the family. So it's a matter of also having several family conferences and trying to understand the family dynamics and even the motivation for the decisions. It is very common sometimes to find that some family members who are opting not for resuscitation or for care to be withheld, some of them, the motivation is actually not in the best interest of the patient, but they're looking at maybe there's wealth, there's a will, what am I going to inherit after this individual has died? So we also need to have the wisdom to try and discern what is the motivation behind the decision that the family members are making. Is it in the best interest for the patient or in the best interest of the relatives?
Thank you so much, Daktari. The next one is to Dr. John Weru. I would like you to comment on what are some of the qualifications and quantities that you want our young health professionals to have so that they can have these discussions, which are not easy to have, and even in normal circumstances. But now we are talking about Advanced Care Directive. So, Daktari, what are some of the qualifications and the qualities that young medics should have?
Thank you, Paul. And I think as we discuss these and discuss about Generation Z and the younger generations in the medical field, it's important to go back to the ethos of medicine from Hippocratic time, Socratic time. What did medicine mean? And coming back to Kantian time in the 20th, 19th century. What medicine and medical practice has meant is one, about the trust relationship, the fiduciary relationship, supererogatory relationship between the patient and the caregiver. That still holds as the emblem of proper healthcare provision. Once you have that, then it's very important that we have professionalism based on critical communication skills. We use the term communication diversely. We ask ourselves, are we communicating? We read about it. It's a very common term that we use. But I can tell you for sure, when it comes to communication, we do fail. Because communication have got key elements. There's the source of the information, there's the route of passing the information, there's the recipient of the information, and there's a feedback process of the information, and the feedback process comes back to the source. So communication skills are very important. And if you read around literature, you'll see that so many tools have been developed on how to communicate. But we still say we do communicate. So that is critical. But as we communicate, let's not forget about that element when we are dealing with someone who requires our care, that we need to be empathic. We need to be compassionate. We need to make sure that we are seeing ourselves as collaborators, as partners in this communication with the patient. We are not, and we should not be paternalistic, know it all, that the patient is a recipient, we are the sayer. Do as I say. Today is about collaboration, partnership based on key, clearly well-stipulated communication skills with empathy and compassion. Thank you.
Thank you, Daktari, for driving that point about communication, which is very, very critical and crucial as we look forward to having medics who are able to offer good care and actually also respect this advance directive. Professor Wanyoro, I would want you to comment on why is this now very important in this time and age. We are talking about advanced care planning in Kenya. Prof, if you're still there. Has Prof dropped?
Yes, Paul. Unfortunately, Prof has dropped.
Okay. Okay, thank you. Dr. John Wero, maybe you can comment on this. Why is this becoming so important now in this time and age that we are talking about advanced care planning in Kenya?
Okay, thank you. And I think it's one, people are getting to know about their rights and also balancing this with their obligations. So rights of patients and their obligations, rights and privileges of clinicians and the obligations they owe both the society and the patient that they are taking care of. But crucially speaking, is the fact that we are getting to a point where technology is catching up with us. We, as of now, have so many technologically advanced ways of testing for diseases, diagnostically or evaluation and monitoring. We have ways of keeping the patient alive for a long time, be it by ventilation, be it by artificial hydration and nutrition, be it by use of inotropes. So the technology that we have then guides us to making sure that by the time we are doing so or intervening technology-wise or technologically, then it's good that the patient know. And then as we evolve, as medicine evolve, there's nothing that is growing as suddenly as technology, and this technology will also be associated with some other ways of communication. And that's why we have to start clearly communicating with our patient as the primary source of information, because Dr. Google is out there. People are on ChatGPT, for example. They're on TikTok. They'll hear about these things. But what they hear out there might not be contextualized within what they require themselves. So we are called upon to make sure that we are in front of doing this kind of communication with the patients and families.
Thank you, Daktari, for that. Dr. Esther Nafura, you can make a comment on, Daktari has mentioned something very important, that we need to bring the public into the know because there is Dr. Google out there, and also our health practitioners need to keep up with the pace in technology. So do you think we have put measures in place in terms of empowering our public and our professions as we talk about advanced care planning in Kenya?
I think we are still a bit far when it comes to empowering the public, because most of the time, even when we have discussions about resuscitation, life-sustaining therapies, which is ICU treatment, it is very common to find that most relatives that we talk to or patients actually have no idea what it means, for example, to be resuscitated. That's why you can find someone saying, I do not want life support, but I want resuscitation. And the question is, what happens after we finish the CPR? What do we do with that patient? So we still need to do a lot of advocacy in terms of people understanding what their rights are, in terms of making decisions about their treatment options. So the focus should be on the kind of treatment that one wants to get. Because when you listen even to our colleagues and ourselves, sometimes when we have discussions with patients, it comes out to be more of a discussion of the treatment that an individual does not want. So it's more about what don't you want than what are your wishes. So we still have a long way to go in terms of advocacy, in terms of educating healthcare providers and the public at large on what advanced care planning actually is and what the benefits are and just how it can make life easier for the patient, the family, the service providers, and really any legal issues that arise in terms of care. If we can start having these discussions and incorporate them into care, even a lot of the ethical dilemmas that we get will actually be minimal because some of these things will already have been addressed and the knowledge has been shared. Thank you.
Asante sana daktari. And I want to throw the same to Dr. John Wero, who works in a teaching institution, and ask the same. Daktari, do you think our medical career, our curriculums in the teaching hospitals take care of advanced care planning?
Thank you, Paul. And you come back to a critical issue that we need to think about, that we need to rethink our curriculum. We need to rethink our way of even offering that curriculum. And if you look at advanced care planning and advanced directives, they're just getting introduced, not explicitly, but as part and parcel of what we call professional skills or common skills. So we are yet to get to that point. And as you had asked earlier, we expect our doctors to have these discussions with the patient, the same way we want them to discuss with the patients about the pain and the pain medications, but we did not teach them. We never took them through the challenges of handling advanced care planning discussions. So it's the high time that this was introduced as part and parcel of the curriculum. It could be a course, it could be a topic, but be offered to all healthcare providers, be they nurses, clinical officers, doctors, and even social workers and those in chaplaincy, because they also are considered as part and parcel of the bigger healthcare providing team.
Thank you, Daktari, for that emphasis. I want to throw the last question to both of you and ask, as you look at our healthcare system, the way it is now, what are some of the critical areas that we need to improve so that we can inculcate this culture of advanced care planning? We can start with Dr. Esther.
Okay, so I think one of the areas we need to improve is to have this continuous sensitization on what advanced care planning is about, what advanced directives are. And the other two key areas is to have the legal backing for advanced care planning, so that the decision that a patient makes, the autonomy that a patient has, or the decisions that a family makes and we document, that actually our law can respect that those decisions were made after a discussion and in the best interest of the patient. And of course, we need policies also within our institutions, within the government, that can build a framework to help service providers as we take care of patients, so that we are within our mandate to offer the best care, but also we can respect the wishes of the patient and still be able to provide quality services for them. Thank you. Back to you, Paul.
Hello.
Yes, I think you want to respond to the.
I think on top of what Esther has said, I believe what we need is an actual paradigm shift, a shift in the way we have our our guidance as far as training is concerned, teachings are concerned. We need to introduce this as key component of the topics that we have, but also make sure that social ethics, bioethics, and law are part and parcel of the training that we take our healthcare providers through, and have the topics of advanced care planning. We also need some standardization. And standardization will start from the law to all the way to documentation, so that this is cutting across and everybody is now comfortable doing the advanced care planning discussion, documenting the advanced directives anywhere within the country. So a shift will also be needed from the social aspect of the people we take care of. We need to train them and teach them and educate them on the fact that advanced care planning is not about death. It's about them making actual decisions at the earliest opportune possible. Thank you.
I want to take this opportunity to thank both of you for that fruitful discussion. And without much ado, I want to look at some of the questions our participants have also thrown, so that we can also make them more involved. And the first question is that when relatives bring their patients to die in hospital, someone has put that into quotes, without a living will or any proxy, but come up with a list of things that should not be done for the patient. What should the healthcare practitioners do? Dr. Wero?
Okay, repeat that, Paul.
Someone is asking, when they bring their patients who is critically ill, probably they have put in quotes to die in hospital, but they have a list of what we should not do. What's your take on that?
I think that's an interesting question, because the default is that everything should be done. So unless it is in keeping with the patient's best interest, then you are not obliged to do what the family is asking you to do, or not to do what the family is asking you not to do. So for the patient. So if they come and say, do not do A, and A can be beneficial to the patient, then you can tell them, we have to do A. This is what we now will call clinical team family conflict in regard to the care for the patient. First of all, do no harm. Non-malfeasance principle is very important. If you believe it will harm the patient by not doing, then you do it. But if you have the privilege of having a hospital ethics committee in your institution, or you have a medical bioethicist who can be able to resolve that, please engage them. Sometimes it's because of hidden agenda that the patient, the family members are telling you, do not do ABC. ABC not to be done should also be said. It's on the call not to do ABC should come either from the patient in form of advance directive, or sit-down discussion, and it should not harm the patient.
Thank you, Dr. And I want also to say that one of our and says that in advance directive, so that all the parties feel protected, service providers and beneficiaries are all will ensure quality of service, and all parties will feel content with any outcome of treatment care given. The next question. Let me see. The next question to Dr. Esther Nafura. I think one of our participants said this is a wonderful presentation. And the question is that to what a patient with terminal illness wishes not to be fed any other way except orally, but now cannot feed themselves.
So remember, as we are respecting the wishes, as Dr. Weru has said, you always have to remember the ethical principles of beneficence and maleficence. So you want to do no harm to the patient. Now document, and this documentation goes into an advanced directive or a goals of care. Home, or so you have to practice also within the policies of the institution. For example, if a patient is in Kenyatta National Hospital and we do not have any documented wishes, then we have to do what we deem to be clinically appropriate for that patient. If we have it documented that the patient does not want, for example, what if support can we still give to the patient that will not lead to them dying faster, because that one now becomes medical malpractice. It becomes some form of negligence possible. What is causing the patient not to feed what are they rated, for example? So we do practice within the institutional policy.
Thank you, Dr. for that response. And I think the next question is by Abdi Harim Bare, who is asking, what as a country are we doing to scale up palliative care for patients who cannot afford these services outside Nairobi? I think both of you are well versed in the
Let Dr. Weru take that first.
Okay.
Okay, Dr. Weru.
I think the growth of palliative care in Kenya can only be said to be exponential. In 2000, we had about 10 palliative care providing units. In 2023, we have more than 80 palliative care providing units, be they hospices, be they domiciled within government hospitals or private institutions. So the growth has been there. And the big question that we need to answer now is how do we make sure that this growth continues? We have a national palliative care policy, 2023-2030, that stipulates what is required for us to provide palliative care, the implementation bit, the arms, and also the necessities. Just 2 months ago, we did update our essential medicines for palliative care for the palliative care field. And we are the one of the team or one of the field that doubled the essential medicine that we want the government to recognize as essential medicine. Today, we are working with the NHIF so that the palliative care become one of the supported field of healthcare provision. We are also discussing with the Association of Kenya Insurers so that the private insurance palliative care, wherever the patient is, be it at home, be it in school for school-going children, be it in hospitals, be it in hospices. So we are in this. The challenge we have, and I can throw back to this team, is that people are still not very interested in getting into the specialization of palliative care. In a country like ours, where we only have 4 palliative care specialists recognized by the Medical Practitioner and Dentist Council, it still begs a question on whether we realize that this is an important component of healthcare provision, or we just take it as just part and parcel of end-of-life care, because that confusion is still with us, that palliative care is equal to end-of-life. Palliative care can be provided for patients who will get on and off it. And that kind of life care, which is a determined kind of timeline. Palliative care is about an approach, and it's about the needs, the suffering, the requirement of that patient at that given time. So my challenge I throw back to this team: please get your people doing palliative care, get the doctors interested. The nurses have done a good job, because I believe as of last year, we had more than 1,000 nurses trained in palliative care, more than 300 of nurses trained up to diploma level, but unfortunately, less than 30 doctors trained up to diploma level, 4 with masters, and others have fellowships. So it's upon us to now bring in this critical part of healthcare providers and also bring in the others. We are encouraging social workers to get into the field of palliative care. We are encouraging counselors to get into the field of palliative care. We are now talking to our chaplaincy team that for you to be engaged with us, you need to at least have done a certificate in palliative care, because essentially these patients have got some challenges that are not with other patients who just came to theater, had an operation and outpatient. So the growth is good, but we encourage our members to be really on top of it and join this rapidly growing and exciting field. Thank you.
Thank you, Daktari, for drawing that challenge, and I'm sure our participants have heard this is a very interesting field, and that they can join so that we can widen the scope. The next question is to Dr. Nafura. As part of advanced directive, is euthanasia medication part of it?
No, euthanasia, okay, in Kenya, euthanasia is not part of advanced care planning. Euthanasia is illegal in Kenya. Actually, it's considered a murder. So we do not talk about euthanasia when we're talking about planning, but in the setups that have euthanasia as an option, euthanasia has its own laws and its own documentation and decision-making process. So it is not part of advanced care.
Thank you for making that clarification to one of our participants. I think the next question is to Dr. Weru. In the incident that a patient chooses a certain mode of treatment and all his relatives are refusing and opting for alternative mode of treatment with threats to sue the facility, if they do what the patient wants, who should we listen to?
Okay, thank you. We listen to the patient. The recipient of any information and the giver of any medical information is primarily the patient. Family members, next of kin, holder of medical power of attorney, surrogates, proxies, come in a distant third. So we listen to the patient, not to anybody else. Sometimes we get this challenge because it's the other party, it's the family members who are paying for the care for the patient. So if the patient say, I want A, and the family does not want, they want B, then there might be a challenge of there not being any payment, and therefore the patient not receiving care. But remember, literally your decision is based on what the patient wants, after understanding the options, and after voluntarily making a decision after fully comprehending what you've given them. So we listen to the patient, not to the other third parties.
Thank you, Daktari. Before I give you the minutes to comment, maybe we can take this last one. One of our participants has asked, how often can advanced care directive be changed? Is it ever too late to review them?
Yeah, this is why we are saying that we need a legal framework for advanced care planning. So currently what is happening is that the advanced directive, it depends on the institution. Some institutions require that patients update their advanced directive every 2 weeks. Some require that whenever the patient's condition changes, whether for the better or for the worse, we need to uphold the advanced directive or confirm that the wishes are still the same. And sometimes the advanced directive is updated as often as is needed. So you could find, for example, a patient who is in an ICU setup, the advanced directive could be updated every few days. For a patient who is stable at home, maybe the advanced directive is updated whenever the patient comes to hospital. For places that have law, like in America, UK, Canada, it stipulates the time frame within which an advanced directive has to be
Asante Daktari. And I think before we cross, I want to ask this to Dr. Weru. A very interesting question that, Daktari, if you're in a healthcare team where you know someone has put advanced directive, but another senior member of the team, a consultant, is ignoring them, what should happen?
Thank you for that question. And remember when we started, we said that advanced care planning with the product advanced directive has got a legal, ethical, and medical meaning. So if we have advanced directives and anyone is ignoring them, then they are culpable of being, one, unethical, two, doing things illegal, because consent is a legal call for care. If a patient has said no kind of care, no intervention, then and you're giving it, you're doing things illegally. And then eventually, medically speaking, we must ask ourselves, for whose benefit are we doing this? We said we are the main advocate for the patient. So what I would do in such a case is, if it's a senior person, it's good to talk to them. But if you have a hospital ethics committee, please always engage them in such a dilemma, because at the end of the day, it's the institution that will be culpable legally before the courts of law, and also the doctor. But pay attention to the fact that whatever is being done, if it was not consented to, then it is being done illegally.
Thank you, Daktari. And I want to take this opportunity to thank both Dr. John Weru and Dr. Esther Nafura for the wonderful presentation. I know we have so much questions out there because this topic is normally very emotive and very interesting. But because of the interest of time, I want to give each 2 minutes to make your closing remarks. So we start with Dr. Esther Nafura.
I would like to thank Dr. Weru for accepting to be our speaker this fine afternoon. And I would like to thank the over 1,200 participants who have stayed with us from 2 p.m. We have this clinical ethics series that we are running every month. We'll be having 2 webinars, and we'll be discussing a lot of the ethical issues that arise in clinical practice and in research. So please watch out for the next webinar that will be coming up on 5th of September. We hope to see you there. And thank you, Paul, for moderating the session very well.
Thank you, Daktari. Dr. John Weru.
Thank you. And first of all, I want to thank the participants for listening in and the contribution and the questions. They are all learning points for all of us. Thank you to the team that planned this meeting. It's a call, it's a critical meeting, and I would recommend that it be done every quarter, so that at least we have so many people hearing about this. Thank you, Dr. Nafura, for the invitation. Thank you, Paul, for moderating this session very, very well. And I would want to encourage all of us to now go out there and think about advanced care planning, not for that other person, but the person that we are going to see immediately after this, the patient you are going to take care of, the patient you will see tomorrow in your clinic, in the ward, and the person you'll meet in the streets, because advanced directive is not for the sick. It's for the healthy making decision for themselves. And eventually, I want to welcome you to our International Palliative Care Conference in November 15th to 17th. It will be in Kisumu, Acacia Hotel, and we'll have a workshop on advanced care planning. So please, if you can attend, let's meet in Kisumu, and asanteni sana.
Thank you to both our presenters, Dr. Esther Nafura and Dr. John Weru, for the wonderful presentation, and to all our participants. Thank you also for listening in and for the active participation in the Q&A. And we hope to see you in our next ethics series. So asanteni sana.